Okay, and we want to use the appropriate terminology. We don't just want to say, oh, our posture looks bad or is aberrant. And let's use that. So slouch forward head posture, okay? How can I quantify a forward head posture?
The plumb line.
Okay, yep, plumb line. So I can, without even a plumb line, I can look right from here. I can see her ear is anterior to the acromion, her neck is, and her chin are jutted out a little bit. So I can see that there's a little bit of increased flexion in her lower cervical spine. To keep her eyes in orientation, she's gone into a little bit of capital extension because you have to do that as your head, otherwise you end up way out here. Okay, what else? Okay, so what shoulder appears higher or lower than the other one? His left is lower, okay? So what do we typically see in most musculoskeletal presentations of a dominant side versus non-dominant? Okay, lower on the dominant. So that's of note to me. You know, that correlates with our presentation for muscle stress, muscle strain, increased muscle tension. What else?
Rounded shoulders.
Okay, rounded, forward, depressed, medially rotated, protracted shoulders. I can see here her scapula are slightly protracted. Okay, if I look at her scapula just here, just briefly, what do I see? Inferior angles, I see some winging, and that's static winging. We haven't even asked her to engage serratus yet. What else? You guys see anything else? Okay, what am I also doing while I'm doing my history and my observation and inspection? I'm buying time, right? If I think she's got a posture dysfunction and she's telling me she's uncomfortable in sitting for long periods of time during the day, I want to see if I can elicit her symptoms in that posture. I want to see if I can provoke those. So I'm going to put her in an unsupported position. I don't want to make her uncomfortable. You know, if she's really uncomfortable sitting unsupported, I'd say, okay, let's get her in a chair that's got back support. But if she can tolerate this, then this just gives me more information to make a good PT diagnosis. Okay, anything else you guys see? Okay, I think that's pretty good. Any tilting of her head to the right or to the left? No? Okay, good. We did all that without even putting our hands on our patient. That's about 20 minutes in. So we're taking a little bit longer, but you see that you can get a lot of information without even rushing to put our hands on the patient. So what do I want to look at next? Active range of motion. Okay, so let's have her look into extension. So look up as much as you can. Okay, and back down. Okay, and then from midline into extension one more time. Okay, and then flexion one more time. Okay, what did y'all see from those different views for flexion and extension? Okay, so she's pretty limited in extension. She gets, go ahead and extend for me. Okay, she gets to about C5, C6, and then the rest of that is coming from the upper cervical, so C3, C4, probably a little bit of contribution from C1, C2, and then she's really arching back to get that nose parallel to the ceiling. Okay, so that's gonna correlate with what of my differential diagnoses? Okay, probably some sort of facet dysfunction, and that could be contributing or could have been caused by some of that adverse muscle tension. Excuse me. All right, how about right and left rotation next? Okay. Okay, limited rotation to the right. Were any of those painful? So extension, flexion, right or left rotation? Okay, so let's go into left side bending first. Okay, and she's kind of cheating a little bit with SCM. So you see it's not pure side bending, and she's elevating her shoulder a little bit. And then how about going to the right? And that shoulder pops up almost right away. So even though we don't have pain, no pain on the left side, there's not pain on the left side, there's something that's going on there. And probably we're gonna see a little bit of symmetrical dysfunction. Anything else that you guys wanna look at? Okay, can we rotate one more time? Okay, she gets there, but it's kind of limited. That shoulder pops up towards end range. Okay, what else?
I just have a question. So when you said like, even though she doesn't have pain going to the left side bending, it's still like there's a difference there. How much of that do you care about? I mean, like, because surely everybody has differences to one side or the other. I mean,
Exactly. So for me, it's symptomatic.
okay.
So what is it that's limited and symptomatic? Have anything to add to?
Well, I mean, I'll take it into account on muscle versus joint. So sometimes it helps me narrow down, you know, if she can't lean to the left, which is pain-free, and then leaning to the right is okay. It might be muscular on the right versus leaning to the right is painful. Leaning to the left isn't, you know, reducing the pain on the right might be more poignant. Sometimes I use those two.
So just be consistent in how you're going through your examination. And then whether or not you choose to use a goniometer and quantify that, whether you use percentages like a lot of us do, really just be consistent in your documentation so you can track progress over time. Okay, what else? Feel pretty good about what we have so far? Does anything that we've seen up to this point rebuke anything that was in our differential list for musculoskeletal causes of pain? Anything that I can eliminate as of yet?
First rib has some neurological.
Okay, so maybe we may still find an elevated first rib because of that limited rotation towards end range and the fact that that shoulder pops up so quickly for side bending and rotation, but it's not a symptomatic first rib. So we're still pretty good with muscle strain or posture dysfunction or facet dysfunction. Okay, so what's the next logical thing that we're going to look at? Okay, we could look at palpation. Okay, we could also get her in supine and look at passive. So that's what I'm going to do next. Can I ask you to lay back on your back for me, please? Did you have any increased discomfort from sitting up that long? Okay.
I
So,
would say I do usually lean to one side because I have more muscle.
so what side do you typically lean towards?
I think that's why my shoulder was higher. I usually lean towards the left.
Okay, so that's something I didn't hear in the history, but that's important to me. So she had a history of piriformis syndrome. She feels like she leans more towards the left, so that's throwing your whole body symmetry off. So that's good to find out. Okay, so let's see. Oh, it's completely for me. I'm just going to take her into passive flexion, passive extension. I'm going to look at side bending to see. I just want to see what in this part of the exam. Exactly. Is the motion there? And when I eliminate gravity and I take muscle contractions out of the equation, I can see that she's got full pain-free range. Okay. I'm just going to check and look at, we're going to do pivoms in the C-spine. Okay, so I like to look at them in neutral, in flexion, and extension. You okay there? Okay, and I'm looking for translations.
What are you feeling right now? What are you
So, right there, tender. Okay, so over the articular pillars, and we do lateral translations, similar to what we did in the lumbar spine with them in side lie, where you're trying to feel the different interspinous movements. So so she's tender at C5 on C6, okay, and that's exactly where I feel restriction. So I can come above that with her in neutral, and I can see she actually glides pretty nicely. I get her down to that next level, and that's it. That's pretty significant. Okay, so let's just treat it real quick. Oh, before we get to that, let's do palpation. So I'm going to palpate the suboccipitals, so I feel like that's a provocating, contributing factor. Is that tender there at all? Okay, I always look at scalenes. Anything in there? Okay, SCM. Anything in the SCM at all? Okay, upper trap. Anything? Okay, I'm going to follow all the way up to the base of the C-spine. I'm going to go for the left side as well. Anything on that side? Okay, nothing there. And then I'll go for levator. Anything there at all? Okay, from this position, I can spring her first rib. Okay, it's got